Hi, I'm Ellen,
And I'm Allison.
and we did our project on the TELE ASD PEDS assessment tool. Our presentation looks a little bit different because we chose to look at an assessment tool as opposed to a treatment procedure. When Margaret Doremus and Dr. Mankowski spoke to us earlier this semester, they discussed the use of this tool for autism assessment due to the virtual climate that we're in. And we thought that this would be a meaningful experience to learn more about this tool since Alton and I will be engaging in an experience at the CIDD this summer.
So our learning outcomes for today are that students will understand why the TELE ASD PEDS was created and will understand the administration guidelines as well as understand the scoring methodology behind the tool.
So to introduce the tool, TELE ASD PEDS is a diagnostic tool for autism spectrum disorders that's intended to be used through a virtual platform. It's meant for children who are 36 months or younger, but should not be used for children who are under 14 months. It's intended to be administered by a psychologist or potentially another trained allied health professional, such as a speech pathologist. And it's to be used in a private clinic room or a patient's home via Zoom or in other HIPAA client compliant platform. But most of us are familiar with Zoom at this point. And at the bottom, we highlighted the names of the primary researchers and creators of this tool at Vanderbilt. These people include psychologists, pediatric physicians, early interventionists, and then some people who are responsible for statistical analysis and the technology side of this tool. So why was it created? It was initially developed as a better model of early screening and evaluation of young children with suspected ASD. And when COVID hit, it was accelerated in its development to support the pragmatic and financial needs of the communities in Tennessee. And the current tools used, such as the ADOS or the STAT, had some limitations that the TELE ASD PEDS was hoping to support or overcome. So this graphic here, we took from a presentation that Allison and I watched on TELE ASD PEDS, and it addresses the lack or the need of earlier interventions or earlier assessments. It's showing that a lot of children are not receiving adult developmental evaluation before the age of 3. And that's what this tool was hoping to overcome by being a tool for earlier evaluation. And so some issues that were currently being seen are long waits to receive an assessment and a diagnosis. And due to these long waits, some children were being lost in the process. And so this next little graphic was also from the same presentation, and it's showing how a parent will start seeing these red flags in their child, but they're being passed from professional to professional before they actually get the evaluation and diagnosis that they're seeking. And so very often families can get lost in this process due to the long waits and the frustrations of not knowing where to go next. So the existing models that I mentioned earlier, such as the Autism Diagnostic Observation Schedule, or the ADOS, we've learned about this earlier in the semester, and it has historically been seen as the gold standard of autism assessment, but it must be administered by a psychologist. And then there's the modified checklist for autism in toddlers, which is a virtual screener that a parent can go and answer 20 questions, and it provides a risk score, and then provides information about what the family should do next, depending on what their score is. So it's asking behavioral questions and then tells the family how they should proceed in seeking diagnosis or more information. And then There's the screening tool for autism in toddlers and young children, which is a screening tool that was also created by researchers at Vanderbilt. And it was the first iteration of the screening tool that is now the TELE ASD PEDS. And its purpose was trying to train other primary care providers in assessing and diagnosing autism, so that there could be greater access for receiving a diagnosis. But the researchers at Vanderbilt felt this was still not enough and that they needed to reach more rural areas. And to do so, they thought that they should create a virtual platform or a virtual system in providing diagnosis, which led to the creation of the TELE ASD PEDS.
Okay, so I am going to be giving an overview of the administration. And it's really important to note that the TELE ASDPs is really just one small component of a more comprehensive assessment. So an entire assessment will generally take about 1 to 3 hours to complete, and the TELE ASDPs portion should take roughly 20 minutes. And so this assessment alone shouldn't be used to diagnose. It's used in conjunction with other tools and other observations and things like that. Things like clinical interview, adaptive information, and observations, like I mentioned. And so to start this process, a clinician will talk with the parent about their concerns, ask questions about the child's development and medical history, as well as then move into asking the parent to observe, interact, and play with their child. So who's involved? It's parents, a psychologist generally, or other professional, and we'll talk a little bit more about that later on. And there are several things that are needed for this assessment. We, or those administering, will ask the parent to provide about 5 to 6 toys for the child to interact with, a snack, a clear closed container, like a Tupperware container, bubbles, and then something like a balloon or a car or a ball, something that's considered a ready, set, go item. And so balloons and cars work really well for this. And this tool is designed to be very flexible. Clinicians will ask the parents to use toys that they already have, and so it's not necessary for them to go out and buy additional toys just for the exam or the assessment, excuse me. So the setting, a table is really helpful, especially a child-sized table, and as well as a quiet environment. So this is often done in the home setting. So things like other family members running around, pets, can often be distracting. And then technology, it's important to have a camera that's set up so that the administrator can very clearly see the child. It's also important to have a backup device like a phone or another computer in case that there is an issue with technology. And then finally, a HIPAA compliant platform is necessary. So like we mentioned before, Zoom is pretty frequently used for this tool. So these are the components of the TELE ASD PEDS. This is the general suggested order of things, but again, things are very flexible, so they do not necessarily have to go in this order. So the first one on here is toy play. Toy play that's child-directed is just providing the child with 5 or 6 toys for them to play with on their own and just see how they interact with those toys. Then toy play that's parent-directed. This is when we would ask the parent to get involved and interact with the child. The next is responding to a social bid. So this would be like saying the child's name and, oh, look over here, and getting them to engage in that joint attention task. Next is ready, set, go play. So I mentioned this a little bit earlier. This would be like blowing up a balloon and saying like ready, set, go, and letting the balloon fly around the room, or using a car on top of a car ramp or something like that. And you're just looking for the child's reaction to that. Next is physical play. Physical play is anything like patty cake or peekaboo, where there's some physical component involved. Next is requesting. This is where the snack and the closed container come in. The parent would put the snack, like a highly preferred snack generally, in the container and close it and then hand it back to the child and see what the child does with the closed container, see if they hand it back, see if they ignore it. That's kind of what you're looking for in this task. And then finally, a toy play that is closed. So the parent is ignoring the child in this. This is generally when the clinician is kind of talking about the assessment and overall observations with the parent, and you're just seeing if the child tries to engage the parent again in play. So some administration tips. It's important to remember that it's okay. If things don't go according to plan, there's a lot of room for flexibility. Instructions can be repeated and clarified, and the materials can differ from administration to administration. They don't need to be very specific. We don't want parents going out and buying materials for this assessment. And it's okay to ask the parent what they saw in the assessment, like, oh, I didn't quite catch where the child was looking, like, what did you see? So getting that parent feedback is also really helpful. And it's also important to be very direct with the parent, so telling them what exactly you want them to do, what you don't want them to do. And another piece of that is being very clear about where you want them and the child to be positioned. And then I pulled this quote directly from the creators of the tool, that this assessment is meant to be a guide that can facilitate meaningful assessment of core social communication challenges and atypical behaviors. So here we have an example rating form, and a full version of this rating form can be found on our Sakai page, so that you can see it a little bit more clearly. So basically the areas that are scored are socially directed speech and sounds, frequent and flexible eye contact, unusual vocalizations, unusual or repetitive play, unusual or repetitive body movements. The child combines gestures, eye contact, and speech. And finally, unusual sensory exploration or reaction. So those are all the areas that are assessed on this tool. And then there are 3 different score possibilities. So there are both a Likert and a dichotomous rating that is used on this tool. So like we mentioned before, this tool is still being developed and perfected and researched. So at the moment, there are 2 scores that are collected. One that's a Likert. So a score of a 1 would indicate symptom is not present. A score of a 2 would indicate a symptom is present, but at a subclinical level. And a 3 would be a symptom is obviously consistent with autism spectrum disorder. And then on the dichotomous scale, a 1 would be the symptom is not present, and a 3 would be the symptom is present. So both of those are collected, and the differences in those scores are still being kind of assessed for which is more reliable at the current moment. And so a score of 11 or greater on this tool indicates an at-risk classification, and a score of 3 in at least 5 of these categories, it would indicate a high-risk classification. So next, we want to talk about some limitations of the TELE ASD PEDS. This tool has not been studied with children with multiple disabilities, or who are bilingual or English language learners. So there's still more research that needs to be done in these areas. And like we've mentioned before, this is still a work in progress. They're still trying to understand the scoring, and there's still some uncertainty and need for further testing. And there's also there's not a lot of clarity around the background of the person administering the evaluation. Generally, a psychologist would administer this, or if it's an allied health professional, it should be somebody who has experience in doing assessments with children with autism, or assessing children who may have autism. And so we wrote here that it's okay to be unsure. Administrators can err on the side of caution when making a diagnosis with this tool. And there's even a place on the rating form to indicate if the clinician feels that they're very confident in their score and would recommend a diagnosis, or are not so confident and would recommend further evaluation. And then finally, there are some obvious technical issues that can occur with this tool. So a call being dropped, or interruptions with internet and things like that are all potential limitations. So lastly, there are some differences state by state. So who can do the assessment may differ state by state. Some states may require it be a psychologist, while others may be more flexible in who can administer this tool. There are also some billing differences state by state. I think previously there were more differences in coverage. So insurance in the past was less likely to cover telemedicine, but now that we're in the COVID area, that has lightened up a little bit. So insurance and Medicaid are more likely to reimburse for this type of assessment virtually. And finally, you can Zoom from anywhere, do this assessment from anywhere, but the administrator must be licensed in the state where the child lives and is being assessed. And we are happy to answer any questions that you all have live in person.
And then here are primary references, and this website link will take you to where we received all of our information from. There are several webinars and research articles and the rating scale and other tools to use. It provides a whole bunch of information that we couldn't all collect just on a PowerPoint. And then also the following reference is for a research article about the creation of this tool, and we took a lot of information from that, and it also has a lot more information about the psychometric properties of this tool, and the data that has been collected and the further research being performed to make sure that this is a reliable tool that can be more widely used in the future. So
Thank you.